Today we're going to be taking a look at the cranial nerves as part of the clinical neurology series. As you may know already, the cranial nerves are 12 pairs of nerves which start from the brain or the brainstem. And we have 12 of these nerves which we number from the front of the brain to the back of the brain, or from the rostral region to the caudal region. Each nerve has its own function, and there might be sensory functions, motor functions, or mixed sensory and motor. In this session, we're going to be having a look at each of these nerves, including their functions, how to test them, and the possible defects which could arise. Let's take a look at the first cranial nerve, which is the olfactory nerve. This is a purely sensory nerve which originates from the cerebrum of the brain, and its primary function is to give us a sense of smell. To test this nerve, we can use special smell identification strips, or we can ask the patient directly if they've had any changes to their sense of smell recently. Naturally, if we have a defect with the olfactory nerve, this suggests that we're going to have some defects with the sense of smell, which is also known as anosmia. Possible causes of olfactory nerve defects can include neurodegenerative conditions, intracranial lesions or head trauma, as well as congenital abnormalities like Kallmann syndrome, which is basically a condition where the olfactory nerve nuclei don't migrate to the right place of the brain. Moving on to the second cranial nerve, this is termed the optic nerve, and it originates from the cerebrum as well. The primary function of the optic nerve is to give us a sense of vision, and to test this, we can look at different factors, including the visual acuity, the visual fields, the reflexes, and ophthalmoscopy. One way of remembering these main tests is by the mnemonic AFRO, so we can test each of these things individually. Defects in the optic nerve can result in impaired sense of vision, as well as pupillary defects. Possible causes behind these kinds of defects can include optic neuritis, which is seen in multiple sclerosis, head trauma and lesions again, as well as ischemia or vascular causes. Okay, so far we've had a look at cranial nerves 1 and 2, and we're next going to take a look at nerves 3, 4, and 6, or the oculomotor, trochlear, and abducens nerves respectively. All three of these nerves are involved in the coordination of eye movements, and to understand this, we first have to take a look at the normal extraocular muscles of the eye. The main extraocular components include the superior, inferior, lateral and medial recti muscles, as well as the superior oblique and inferior oblique muscles. Although it may seem that each muscle is contributing to its own movement, in reality it's much more complex than this, and the eye movement is controlled by multiple muscles acting at the same time to give us the end result. To keep things simple, we can take a look at which nerves innervate which muscles. For example, the oculomotor nerve actually innervates the majority of extraocular muscles, including the superior, inferior, and medial recti muscles, as well as the inferior oblique. In addition to this, the oculomotor nerve also innervates the eyelid muscles and allows for pupillary constriction. Comparing this with the trochlear nerve, this innervates the superior oblique muscle, which actually has an inverse relationship, so it results in the eye moving downwards and inwards. Finally, the abducens nerve is responsible for innervating the lateral rectus muscle, and this allows for abduction of the eye or an outwards movement. The sixth cranial nerve is actually a bit easier to remember because the word abduct is basically in the name abducens. Keeping this in mind, let's take a look at what would happen if we had a defect in the oculomotor nerve. If this happened, we would lose control of the inferior, superior, and medial recti muscles, as well as the inferior oblique muscles. This means that the only muscles functioning would be the superior oblique and the lateral rectus muscles. Because of this, in an oculomotor nerve palsy, we would end up with a downwards and outwards eye. At the same time, the oculomotor nerve also coded for the elevation of the eyelid muscles and pupillary constriction. So if we lose both of these functions, we end up with a ptosis or eyelid drooping, as well as a dilated pupil. And you can see the end result of all of these changes in this image here. Alternatively, if we have a palsy of the trochlear nerve, here we lose control of the superior oblique muscle, and as a consequence, the eye cannot move downwards as well as before. This results in difficulty looking down, as well as vertical double vision. Patients sometimes compensate for this by tilting their head away from the defected side. Here is one example of a patient with a trochlear nerve palsy in the left eye, and you can see that it's tilted slightly upwards compared to the right eye. Lastly, in an abducens nerve palsy, we would have issues with innervation of the lateral rectus muscle, which means that the eye would not be able to abduct properly, resulting in a horizontal double vision. In these cases, the patient often tilts their head towards the affected side to compensate for the defect. And again, we have an example of a left-sided abducens nerve palsy here. Putting all of this together, we can say that the functions of cranial nerves 3, 4, and 6 are to control the movements of the eyes. To test them, we can ask the patient to follow our finger with their eyes, and we can assess using a H pattern to see if there's any vertical double vision or horizontal double vision present. The defects would depend on which nerve is affected. So with an oculomotor nerve palsy, we might get a down and outwards eye. With a trochlear nerve palsy, we may have difficulty looking downwards, and in an abducens palsy, there might be weak abduction of the affected eye. Okay, so there's one nerve that we actually skipped earlier, which is the fifth cranial nerve, or the trigeminal nerve. And this is a mixed nerve that has both sensory and motor properties. As the name suggests, the trigeminal nerve is actually composed of three main branches, which include the ophthalmic branch, or V1, the maxillary branch, or V2, and the mandibular branch, also known as V3. Each of these branches will provide sensation to different parts of the face. So you can see that the ophthalmic branch is coding for the green region, maxillary for the purple, and mandibular for the red. As well as this, the mandibular branch also has a motor component, which means that it controls the movement of the muscles of mastication, including the masseter and temporalis muscles. We can therefore say that the functions of the trigeminal nerve are to provide sensation to the face and control the muscles of chewing. To test it, we could check the sensation of the face by using both light and sharp touch on the different regions of the face and asking the patient if they can feel it. In terms of the motor component, we could test this by asking the patient to clench their jaw, and we could also potentially check the jaw jerk reflex. In terms of the defects of the trigeminal nerve, this depends on which branch is affected. So we might get sensory loss of a region of the face, or we may get motor weakness and chewing, depending on the branch which is defective. The next nerve that we're going to take a look at is the facial nerve, or cranial nerve number 7. This is also a mixed nerve which has both sensory and motor properties. One of the main functions of the facial nerve is to control the muscles of facial expression. So we can ask the patient to raise their eyebrows, close their eyes, puff out their cheeks, and smile to test its function. As well as this, the facial nerve also has a few other functions, including sensation of the anterior 2/3 of the tongue, lacrimation or tear production, and innervation of one of the muscles of the ear known as the stapedius, which helps to protect the ear against loud noises. When we have a defect with the facial nerve, this can result in impairment of all or some of these functions, and we can focus on the effect it would have on the muscles of facial expression first. In this case, you can see that damage to the facial nerve may result in inability to wrinkle the forehead, a drooping eyelid, loss of the nasolabial fold, and an asymmetrical smile. When we have all of these changes to facial expression due to damage to the facial nerve, this is referred to as a Bell's palsy. Combining this information together, we can see that the function of the facial nerve involves both the sensory and motor component, with the sensory component focusing on the anterior 2/3 of the tongue, while the motor component focuses on the muscles of facial expression and innervation of the stapedius in the ear. To test the nerve, we can assess the motor component by asking the patient to perform the movements described on the previous slide, and we can also ask if they've had any changes to their sense of taste to assess the sensory part. As we mentioned before, defects of the facial nerve can result in weakness of the muscles of facial expression, and they can also lead to a loss of taste. Following this, we can take a look at the 8th cranial nerve, which is known as the Vestibulocochlear nerve. This is another purely sensory nerve whose main function is to provide us with a sense of hearing. To test this, we can either perform a crude hearing test by whispering a number in the patient's ear and asking them to repeat it, or we can test it a bit more closely using the Rinne and Weber tests. As you can imagine, defects in the vestibulocochlear nerve can result in hearing impairment or a sensorineural hearing loss pattern. This can occur in pathologies such as age-related hearing loss, viral infections or ototoxic drugs like gentamicin, or noise-induced hearing loss, which can occur due to exposure to loud sounds over an extensive period of time. After this, the next set of nerves we can take a look at are the Glossopharyngeal and vagus nerve, which are cranial nerves 9 and 10 respectively. The reason why we group these nerves together is because they both have quite similar functions. They're both involved in swallowing, the gag reflex, and innervation of the muscles of the pharynx and larynx. In terms of the unique features, the glossopharyngeal nerve is involved in the taste sensation of the posterior third of the tongue, as well as innervation of the parotid gland. Alternatively, the vagus nerve is involved in the position of the uvula. If we therefore have a defect with the glossopharyngeal nerve, this can result in impairment of all of these functions. So there might be swallowing impairments, gag reflex impairments, and a change to the sensation of the posterior third of the tongue. Defects in the vagus nerve might also lead to similar symptoms, but a couple of key differences are that vagus nerve defects might cause hoarseness of voice, as well as deviation of the uvula away from the lesion. What this means is that, for example, if we have a left-sided vagus nerve lesion, this will result in the uvula being deviated towards the right-hand side, and vice versa. To summarize all of this, we can see that the glossopharyngeal and vagus nerves have a range of different functions, and to test them, we can assess the patient's swallow and cough. In some instances, we can also test the gag reflex, although this is not typically done in clinical practice. As mentioned, defects with either of these nerves can result in a range of different symptoms, including issues with swallowing, the gag reflex, changes to taste, or hoarseness of voice. Moving on, the next nerve on our list is the accessory nerve, or cranial nerve number 11. This is another purely motor nerve which innervates specific muscles in the neck and shoulders. To be more specific, the accessory nerve innervates the sternocleidomastoid muscle, which is involved in neck turning, as well as the trapezius muscle, which is involved in shoulder elevation. It therefore follows that to test this nerve, we can ask the patient to shrug their shoulders and turn their head against resistance. If we have a defect with the accessory nerve, this will therefore result in shoulder weakness, neck weakness, and sometimes a winged scapula on the same side as the defect. Let's now move towards the final cranial nerve, which is the hypoglossal nerve, or cranial nerve number 12. This is another motor nerve whose main function is to control the movements of the tongue. To test this, we can ask the patient to stick their tongue out and move it from side to side. Similar to accessory nerve palsies, if we have a defect with the hypoglossal nerve, it will result in the tongue becoming deviated towards the side of the lesion. For instance, in this case, you can see that the tongue is deviated towards the left-hand side, and we also have some wasting present on the left too. Putting this together, this suggests that we have a left-sided hypoglossal nerve palsy. To finish off, we have a summary table here, which outlines the key functions of each of the 12 cranial nerves. I hope you found this video helpful, and I'll see you in the next one.